Welcome to another just-in-time video from RAPM. Today we're going to be talking about sepsis with two experts from the Children's Hospital of Los Angeles. There are a few things that are more frightening than a child who's crashing in front of your very eyes, and so we wanted to provide some immediate assistance for folks who may be anticipating an arrival of a sick kid to their hospital with concern that that child is septic. And today we are joined by Dr. Ara Festekjian. He's a pediatric emergency medicine physician at Children's Hospital Los Angeles, where he also serves as the QI director for the Division of Emergency and Transport Medicine and has a special focus on pediatric sepsis. And by Dr. Brad Goldberg, who's also a pediatric emergency medicine physician and serves as medical director for emergency management at Children's Hospital Los Angeles. Thank you both so much for joining us today to talk about a really scary thing that can happen to children, which is they, like any other human, can go into septic shock.
Thank you for having us.
Great to be here.
Let's dive right in. What is shock and how do we know it when it's happening?
So pediatric shock is the concept of a syndrome where there's dysregulation and the metabolic demands of the vital organs of the body are not being met. Essentially, it's a supply and demand kind of issue. The body's overwhelmed, it still needs to meet the demands, but it can't. And that creates a vicious, humbling cycle that the patient can ultimately succumb to if you don't do the right things. The key about pediatric sepsis is that kind of physiology where there's disarray and dysregulation can exist without hypotension. A lot of docs get into the situation where they wait until the blood pressure drops before they act, and that sometimes can get you into trouble. So the key in understanding pediatric septic shock is that you got to start restoring the perfusion right away and not wait until the hypotension starts, because it might be too late if you wait that long.
I feel like that's such a common thing that we see with kids, and we talk about it a lot in the trauma space as well. Like injured kids who are bleeding out will maintain their blood pressures to an extraordinary degree until they just fall off a cliff. And it's the same with that septic shock approach.
Yes. So the children with septic shock can present in two ways. They can come essentially in extremis, where you're doing everything for them, whether it's their airway support, their blood pressure support, their oxygen support, or they can come in that situation where they don't have hypotension and it's considered early or compensated shock. Compensated shock is kind of a misnomer because technically the body is not compensating because you still have the shock physiology. What that term says that they're compensating in that they're trying to maintain their blood pressure as much as they can. And then this is kind of a spectrum where we don't know the exact time point where they change from compensated to uncompensated. If you catch them early enough and you can start restoring their perfusion soon enough, you can try to prevent the hypotension that comes with it. So that helps understand the pitfall when it comes to kids when people wait just because the blood pressure is okay. When you have compensated shock, you'll have tachycardia, you'll have tachypnea, you'll have potentially slightly delayed cap refill. You might, if you're a younger kid, you might be fussy. If you're an adolescent, you might be agitated. You may not be wanting to talk to the people that are walking into your room to take care of you. The key to remember in this state is it's unexplained tachycardia. So you count for the pain, you count for the temperature, you count for the crying, and after that, you still have tachycardia that you can't explain. Is the thing to think about when you have compensated shock. When you
like they're waiting, they're trying to tell you something, but they aren't screaming it just yet.
That's right. The orthostatic changes in blood pressure, I leave that in italics because these kinds of kids aren't in such a situation where you're going to be subjecting them to that if you're going to do it the right way. So it's listed in some textbooks, but I rarely use it. So that's why it's placed in italics. The other stuff, the unexplained tachycardia being the key point, tachycardia, tachypnea, when you don't have an obvious explanation for those, is when you start thinking about compensated shock. When you transfer into the uncompensated shock stage, essentially the hypotension starts, the compensatory mechanism that you had in place that was actually maintaining some sort of perfusion and your blood pressure are decreased. And so your heart rate continues to get escalated, your respiratory rate continues to get escalated, and your cap refill becomes markedly delayed. And these are the kids that will just be irritable and won't be consoled by their parents, or the adolescents that start to get beyond just agitation, start to pull stuff off. Those are the kind of things that I've seen when they get into this stage.
And I'll add that when patients come to the ED via EMS or by self-arrival, they don't show up with a chief complaint of I have sepsis, or EMS is often not relaying to us that word or term. That's not a word or term we hear from EMS commonly. They'll just tell us what they know, the facts. There was fever, there was vomiting, or difficulty breathing. And for most cases that I have seen, most do not arrive in extremis on arrival. And it's this kind of smoldering fire that is happening right in front of us in the ER. And our goal is not to let them fall off that cliff that is coming, and start to restore perfusion early in their ER stay.
Which is why for kids, the existence of shock without hypotension is just one of the key points to drive home today.
Absolutely.
And the last thing I'll add to that too is when they arrive via EMS or by car and they go through registration, these kids are stressed out. They're crying, lights and sirens, and they have this kind of surge upon arrival. And once they relax in the emergency department and we get a second set of vitals, that's where we might start to pick up on these signs of, hey, they are still really tachycardic, and it's not quite fitting it's not quite a appropriate level of tachycardia for what's happening currently.
Right. Like a 10-year-old who's just upset about an ambulance ride should not have a heart rate of 160, right? Like it just doesn't make sense. Yeah.
Yeah.
All right. So let's talk about how you can recognize this, catch it early, intervene, and then what that intervention looks like.
So with this slide, what I like to get across is those emergency departments, regardless of their tertiary care centers or rural centers or whatever they may be, any place that has a system in place of some type of recognition and some type of a trigger alert, or a trigger that says, okay, we're going to do this and this and this, this and this and this, being the surviving sepsis bundle. Those emergency departments that have some system in place where they check that and they see how they adhere to it, those emergency departments seem to work better than places that don't have something existing. The something existing can be as simple as somebody in triage letting the doc in the back know, hey, I'm worried about sepsis. Is this something that you want to trigger the sepsis bundle for? Versus sophisticated systems such as an electronic web crawler that punches in the heart rate, the vital signs, and potentially some other variables along the way once they get settled into the emergency department. And then that triggers an electronic alert, which now also drives the sepsis bundle in place. So there's plenty of evidence showing that if you have some sort of system in place that you're following, and you're checking to see whether or not your providers are following it, those kinds of places have better metrics in terms of how they treat and how they adhere to the surviving sepsis bundle. So the surviving sepsis bundle comes from the Surviving Sepsis campaign, which started actually in 2008. It's an article that gets updated every 4 years, the last one being in 2020. And that bundle essentially says restoring perfusion, so restore volume, get blood cultures before you start any antibiotics, give broad spectrum antibiotics, check the blood lactate, and give support, whether that be airway, blood pressure, hemoglobin, however you're going to give that support. And all of those support steps, always think of it early. Again, going back to the shock existing without hypotension part in terms of teaching to people that don't see kids that often. If a child comes in and they're persistently tachycardic, their mental status is still not improving, and they're not making urine compared to the historical value of what the family gave when they were at home. If you see that the blood pressure is fine, but all those parameters don't show a restoration of the patient's perfusion, you need to act early. I have started vasoactive medications in kids without having hypotension, and it ended up being the right call the vast majority of the time. So if you have markers that are showing that you're not restoring perfusion, even though you still have normal blood pressure for age, you could, there's still there, that's the room you have to save this patient from going from compensated to uncompensated shock. There are times where you'll intervene, you'll start the vasoactives appropriately on time, and they'll still decompensate. And that's the humbling part of sepsis, because once that cascade gets triggered, sometimes it's hard to pull back from it, which is why the kids that come in extremis are so much harder to treat, and it takes a lot more to try and bring them back than the ones that don't come that way. So we've seen patients being able to avoid the intensive care unit simply because of the fact that we gave them so much volume and so much time. Or patients historically that were in the intensive care unit for 3, 4, 5 days on 2 to 3 days of vasoactive drugs end up having just a 12 to 20-hour stay in the intensive care unit because we started the vasoactive drugs early, and they were, because of that, they were able to wean early and get out of the intensive care unit. So there's evidence to suggest that acting early appropriately when you don't have all restoration or perfusion really helps the patients out.
Yeah. So just be aggressive. Like,
yes,
don't worry
yes.
about vasoactive side effects as much as you're worried about getting behind on your sepsis.
The other part to point out, what you said brings up the issue of with kids, their access becomes an issue. So they may have an IV.
That's a great point.
They may not have a central line, and you're out there alone at 3 o'clock in the morning. Don't hesitate to put in an IO. So it's not that these docs don't want to be aggressive. They want to be aggressive, but they hesitate when it comes to putting an IO, which is potentially a painful procedure on somebody who's young that they're not used to doing that. So put the IO in, because the IO, you can give volume, you can give vasoactive drugs through the IO, and it buys you time until you get them transferred out to a setting that can put a central line, or it buys time for you to get another peripheral IV when you're getting help from the nurses. The other things that, so now that you got into the algorithm, if you notice on this algorithm, the first line vasoactive drug used to be dopamine. And for older kids, children and older kids, now the first line agent is epi or norepi, depending on the setting, and it's not dopamine. So historically, a lot of people hesitated to give epi through a peripheral IV. And that's sometimes people will run into that trouble where they'll wait off and not give it because it's only a peripheral IV. Give it to the peripheral IV, because the consequences you're going to have from them bottoming out with their reserves, which they have already done, with their blood pressure going even lower, are going to be worse than the consequences of using epi via either an IO or a peripheral line.
Those are awesome pearls.
Yeah.
Yeah, I think that's an important message for people to hear.
We hear frequently still concerns about running vasoactives peripherally, whether it's other hospitals speaking to us by phone or speaking with colleagues in other institutions. And I think, there's been a shift in general emergency medicine with adults, recognizing that it is safe to temporarily run vasoactives peripherally. And I think there's this added fear in doing it in children with their very tiny little extremities and smaller vasculature. But our experience is we've had great success doing that. And I think the key is that, yes, of course, we're not going to run high-dose vasoactives for days through a peripheral IV. This is a temporary measure. And the most important thing is just having your frequent reassessments of the IV site. So if that line does go bad or infiltrate, it'll be quickly recognized and stopped. So I think that's the key there. It's just as long as you're reassessing the IV site, it's definitely safe and recommended to run it peripherally.
And you'd run those through an IO as well?
Yes.
Yes.
Yeah.
What I've typically done is my great nurses have been able to put a peripheral IV, and I start the vasoactive drug. So basically I buy time and I work on a fem line right after that, assuming I've secured the airway if that was necessary. Going into the algorithm for children, the way this is different is that the first line agent is still dopamine for neonates. And that's because they kind of retain the in utero physiology when it comes to their cardiac physiology. And still dopamine is the first line agent that's recommended for newborns or neonates in the neonatal intensive care unit. So for the doc who's all alone, 3 o'clock in the morning, this is going to be the 7-day-old baby or the 12-day-old baby that was at home, all of a sudden not doing well, maybe getting apneic, maybe turning color, or maybe having a fever. And this kind of patient, not only are you going to support the airway, but your first line agent is going to be dopamine. Down the line, if you need to, you can still add the other agents, but that's how it's distinctly different compared to children and adolescents.
Yeah, and obviously,
yeah.
These slides are busy. There's a lot of information here, a lot of detail. But this is just to make the point that there's an infant guideline, and then there's an older child guideline. And that people can readily find online, right?
Yes. And the biggest difference between them, in terms of assessment, in terms of the laboratories that you're going to send, in terms of the support you're going to provide for the airway, their hemoglobin and all that, it's very similar. The stark difference is the first line vasoactive drug, which used to be dopamine also in children and adolescents, and now the recommended agent is not dopamine as a first line. If you're stuck, you're in the middle of nowhere and you don't have epi and you have dopamine, then you're going to use dopamine. It's not as though you're not going to use it. The reason why that changed is because high doses of dopamine, we're talking above 15 micrograms per kilogram per minute to 20 micrograms per kilogram per minute, you're getting into the range where you're going to have potentially fatal arrhythmias, and dopamine has been associated with that. So if you have it and you can maintain the blood pressure by running 10 micrograms per minute dopamine, fine, because epinephrine is not around, do that. But if you have the ability, you have access to both, then the first line agent is epi and not dopamine. To summarize the algorithm, there's a lot going on in the first 15 to 20 minutes. There's a lot going on in the 20 to 60 minutes. And then after that, you're kind of trying to fine tune. The point that I want to drive across for the 3 o'clock in the morning physician who's all alone is they're not going to be able to get this patient out in the first 15, 30 minutes. The kid's going to be there for several hours. And for us, the ICU isn't coming up and scooping them up at the 30-minute mark. They're in the emergency department for many hours. So Brad mentioned this earlier, frequent reassessments, and then seeing what else you can fine tune, which comes down to the bottom part, further down in the middle to the bottom part, where it asks about catecholamine resistant shock. So if you have adrenal insufficient kids, this is where your steroids will come into play. The way somebody might get into trouble is they might think that a patient doesn't have an altered steroid axis. For example, you have an asthma patient who's very hard to treat, is on chronic steroids for a long time, and just got a recent bout of stress steroids because they had another asthma attack, and they coming in with sepsis and their blood pressure is just not responding despite everything you're doing. Think about adding steroids to the regimen for somebody who might be adrenal insufficient or relative adrenal insufficient because they're in stress. Obviously, there are patients, hopefully not coming to the most rural places, but patients such as congenital adrenal hyperplasia, kids that with leukemia who have steroids as part of the chemotherapy regimen who are steroid insufficient. So there's other kinds of patients where that plays a role. But what I would guess the general emergency department physician would run into this would be an asthma patient who's on higher doses of steroids, and there normally would be because their asthma is poorly controlled. Some patients that are on transplant patients, like liver transplant, kidney transplant, they're on low dose steroids, at least when they get settled into their transplant status. So I'm hoping this kind of patient doesn't show up with septic shock to a rural place because of all the services they would need for their graft to do well with the graft. But if they do, that's another type of population that you're going to have to think about that. The other thing that gets some people into trouble is kids are notoriously volume responsive. So what that means is they can tolerate a good amount of volume, and sometimes they need a lot of volume because a lot of them come in with vomiting as their symptom or diarrhea as their symptom, and that's what got them into the shock as part of their patient characteristics. So they end up needing a little bit more volume than some of the older patients that come in with sepsis. But that can also get you into trouble if you're not checking frequently their lung exam, whether or not they're developing a gallop. So people run into trouble on one end by not instituting stuff promptly or hesitating to give vasoactives because they don't have a central line of the examples that we gave, or they go overboard with the volume and fail to recognize that there might be a component of cardiogenic shock that has started because sepsis affects every single organ, and keep giving them volume is actually going to make them worse. You need to back off and potentially give them PEEP or secure an airway, and then add the vasoactives instead of just solely relying on volume. That goes back to the situation where they don't have a central line. They see that the patient is not fully restored well. So they saw that initially the volume was helping the heart rate a little bit, but now the heart rate is back up. And then they pull the trigger of giving more volume without checking to make sure there's no crackles, there's no gallop, there's no, the liver's not down. That's where the fine tuning, which is usually at the past the 60-minute mark, comes into play. Or it could be sooner if you had to slam them with volume in the first 10 minutes, you had to give them 60 per kilo right away. There are some patients that require that. So the key is the frequent reassessments to make sure that what you're doing is actually making progress for the patient instead of worsening the patient.
Yeah, no, that makes really good sense. Like, and so many great pearls in all of that you just said. I think
Can I add a tip
clearly,
here?
oh yeah, absolutely.
Yeah, I just want to add, another place I think I used to get hung up, and I know frequently people do get hung up, is around the decision about warm shock or cold shock and which vasoactive you're going to pick. It seems in recent years, PALS has de-emphasized a little bit the differentiation in their visual algorithm of going warm shock or cold shock. As you can see here from the algorithm from American College of Critical Care Medicine, that it still very much speaks about it in the algorithm. I think, my recommendation would be do your best at making an assessment, but go ahead and pick a vasoactive. I feel sometimes people get scared at this decision point and then do not start the vasoactive because they might not be entirely sure. But my recommendation would be start something and you can always adjust it. I think norepinephrine is a great choice because you're going to get increase in your systemic vascular resistance. You don't have to think as much about high dose versus low dose epi and the different receptors. So if you're not sure, like that, my kind of fallback is like norepi is not a bad choice, but don't get hung up on the step and overthink it. Like do your best assessment and pick a vasoactive and start it.
That's awesome.
I echo Brad's thoughts because the warm shock to cold shock differentiation is very hard to do at the bedside. This is the literature on that comes more from people that have data to values coming from a central line or a central access, and a lot of times you don't have that in the emergency department, and you're going to have to make decisions without that kind of information. And let's say you're in a situation where you chose, let's say you chose norepi, and it turned out to be the wrong drug to choose for whatever the situation was. It's not going to harm the patient. It's not going to harm the patient. All you can do is gradually switch over and then get them changed over to epi. We've done that in our emergency department all the time. We start them on epi, we follow them up, and we see them in the intensive care unit that they weaned the epi and they started norepi, or vice versa. I have a running joke that we start one thing and they always change it to the other, and then the next time we start the other thing and then they change it to the other, even though the circumstance was exactly the same. What that means is it probably doesn't matter. Just pick a drug and start it. Don't hesitate to start it just because you're trying to figure out warm shock, cold shock, that kind of differences. If
Absolutely.
they're showing signs that they're not restoring their perfusion, start a vasoactive drug. So if you have nothing but dopamine, still use it. Don't put off adding it. But if you have epi or norepi in the children and adolescents, that's going to be your first line agent in your not rural setting.
So obviously, like, you're in a small rural emergency department, and a 3-year-old with a liver transplant, a bad asthma history comes in, like, you're calling your friends. But it sounds like not unreasonable to reach out to your local referral center early in this process, right? I mean, many of these, like these kids are not going to be admitted to hospitals that don't have PICUs, so they're going to be transferred. So when's the right time for people to pick up the phone and say, like, this kid is probably coming your way?
Whenever they have a question, whenever there's the earlier the better.
Fantastic. Well, thank you both so much. I think this has just been so illuminating. And I think the everything from the simple things like don't look for hypotension to the some of the complexities around which vasoactive to choose and when and how to get it in. I mean, I think so valuable, and I really appreciate your taking the time to boil it down to what people really need to know about taking care of kids with sepsis.
Thank you very much.
Thank you.